talking in any forum, we can give our own statistics. So this is the statistics for United States that ART pregnancies now accounts for 1.6% of all infants and 18.3% of all multiple birth infants. And although most of these pregnancies are uncomplicated, IVF is associated with several adverse maternal and perinatal outcomes. Why so? Why these ART pregnancies are at higher risk? Maybe because of the advanced maternal age. Maybe they already have pre-existing comorbidity. Maybe the cause of their subfertility itself. We no more use the word infertility because it's a very, very crude term. We call it as subfertility, which gives them hope. Maybe whatever drugs we are using for ovarian stimulation, maybe she has undergone so many previous surgeries, that is also affecting her ART pregnancy, and can be because of the IVF procedure itself. So it is like kabhi khushi, kabhi gham. On one hand, ART elevates the burden of infertility on the couple as well as families. India में तो हर family को बच्चा चाहिए शादी के 1 साल के बाद ही. But it can also present challenges. And what are those challenges? They are in the form of high rates of multiple delivery, preterm delivery, and low birth weight delivery. तो subfertility में जब patient pregnant होती है, we always tell them when they come to us, it is a multi-hurdle race. Just because you have become pregnant, there is no point that you should be very, very happy because still you have to undergo 9 months journey to get a happy baby in your hand. So ART pregnancies, are they different? Yes. They might be associated with higher risk of complications, and there are only 2 higher risk of complications, that is due to multiple pregnancies. I know every finger gets pointed towards the IVF consultant because they say you are transferring more number of embryos, that is why you are getting more number of multiple pregnancies. But ART pregnancies can also get more complications even if it is a single pregnancy. So you cannot point all the fingers towards the number of embryos transferred or towards the multiple gestation. This study will clear my point very well, that this was published in 2017, that increased risk of obstetric complications from ART appears to apply to twin gestation as well as singletons. So what are these risks? Now we are saying risk hai, to kya hai? Risk to the mother and risk to the baby. So what are the risks? First, the risk of miscarriage or ectopic. The risk is 15% in those women who are less than 35 years of age. It increases to 25% if the woman's age is between 35 to 40, and it jumps to 35 years if woman is more than 42 years. Why I am showing you this age-wise criteria? Because previously, when I was also in private practice, if any woman who is more than 40 used to come to my OPD, I used to think that she has come for abnormal uterine bleeding and she wants to get rid of her uterus. But now, we are getting more and more women in their 40s who are coming to our OPD because they want to have a child. And according to new ART Act, safely you can take women up to the age of 45 years for their subfertility treatment. So just don't think that they have come to you for abnormal uterine bleeding. The second maternal risk is of course because of multiple pregnancy, and if she is having multiple pregnancy, of course, more risk of abortion, more risk of gestational hypertension, more risk of placental abruption and placenta previa. Third risk factor is increased rate of obstetrical interventions. There might be increased rates of induced labors and elective caesarean delivery. And never forget the psychosocial impact of undergoing that ART, and we will discuss that psychosocial impact in another slide. This was all about the maternal risk. What is the fetal risk? Fetal risk are two, chromosomal and fetal risk because of multiple births. So chromosomal risk can be de novo. These de novo chromosomal abnormalities in IVF ICSI babies, especially if you are doing it for male factor infertility. Like couple is having severe oligoastheroteratospermia, yes, they are more prone for chromosomal abnormalities. Second chromosomal problem is aneuploidy pregnancies because our mothers are more than 35 years of age, so it is related to the advanced maternal age. Yes, if it is a multiple birth, then fetal risks are in the form of prematurity, low birth weight, increased neonatal morbidity and mortality. So now what is the best way to protect the mother's health and that of the baby? Regardless of how the pregnancy occurred, definitely you all will say it is the good antenatal surveillance. Why? What are the goals of having this antenatal surveillance? Because you all want to triage your mothers into high risk and low risk. I know any low risk pregnancy can become high risk pregnancy at any given point of time. The maternal complications, and fourth is to decide the time and mode of safe delivery. So is there any standard protocol for this antenatal surveillance more so for IVF pregnancies? The answer is no. So now let us start that she has done IVF procedure, she has got her embryo transfer, and after that, immediately after 1 week, she has come to your OPD. So how you will manage her? She will be bringing the IVF chart with you and all the medication she is taking. So the first and foremost is that you have to continue the progesterone support which that IVF center has started. How long? It is individualized according to the patient's profile. Micronized progesterone vaginally is the drug of choice. Usually we continue up to 12 to 14 weeks of pregnancy. Once the placenta takes over the charge of producing SCG, we stop this progesterone support. Do continue folic acid supplementation. If she is on any thyroid medication, you have to continue it, and of course other medication as well. What I mean by other medications, sometimes we do put them on aspirin, we do put them on low molecular weight heparin, because if it is an 8 donor cycle, so the protocols are different. You have to read what she is undergoing and don't stop those medications till she becomes 12 to 14 weeks of pregnancies. Blood test, yes, we do all the blood tests before we recruit her for IVF cycle, but once she becomes pregnant, you do according to your antenatal protocol all the blood tests which you are doing. Apart from that, sometimes you have to do for SCG titers, because you have to document that there is a rising SCG titers. You have to sometimes do the case specific additional blood test, and we are in Vidarbha, which is more prone for hemoglobinopathies. So if she has not undergone hemoglobinopathy screening, you should test her for sickle cell and thalassemia test. Dr. Chaitanya was talking about ovarian hyperstimulation syndrome. Yes, because if you have got more eggs, does not mean that you should be more happy, because sometimes abundance is not a good thing. In this context, what every obstetrician should know, they should know that OHSS can be early or it can be a late OHSS. Early OHSS you will not encounter because it generally presents 3 to 7 days after SCG administration. That is when we give trigger. So we are doing ovum pickup, and usually after 3 to 4 days of our egg pickup, they get the signs and symptoms of OHSS. Late OHSS, yes, everyone should know, because these cases they present 12 to 17 days after the SCG trigger. That is 15 days after egg pickup and 13 days after embryo transfer, which is the time where you will be doing either urine pregnancy test or beta SCG to confirm whether she has become pregnant or not pregnant. So late OHSS is induced by endogenous SCG from the trophoblast of the implanting pregnancy, And if you are doing the first SCG titer, that is after 13 to 15 days of embryo transfer, what I meant by rising SCG titer is that after 48 hours we do second sample to see that these titers are rising. OHSS, yes, in IVF, now it's a thing of the past, unless and until some IVF center, they are using agonist protocol. I know all the guidelines are endorsing what Dr. Chaitanya Shemikar has said for IVF, agonist protocol, antagonist protocol, agonist trigger and freeze all embryos. But friends, don't forget that even letrozole can give rise to OHSS, though very rare. You all are very Google savvy. Just go on Google that letrozole has also caused a sextuplets, 6 pregnancies just on letrozole. So you just cannot close your eyes that your patient is on oral ovulagens and she will not have the OHSS. So everyone should know the principles. The moment you are doing ovulation induction, you should know everything about OHSS. So if your patient develops it, it is monitoring, supportive therapy, maintenance of intravascular volume. Prevention is the best, but if she develops any complication, you have to treat it, and every time, every step, you have to go on counseling the patient, the husband and the whole family. Mild to moderate OHSS is outpatient care. Severe OHSS is definitely inpatient care. So for mild to moderate, you have to limit her activity, means she has to take rest at home. You have to do her weight daily, monitor input-output chart, daily follow-up and report of symptoms. This you can do on OPD basis. But if she develops severe OHSS, you have to admit her and you have to manage her aggressively, because if you don't monitor her aggressively, she might land up with renal failure, ARDS and DIC. So the implications of severe OHSS are really severe in nature. Who are at risk for OHSS? That also you should know. If she is very young, if she is having low BMI, if she is having a case of PCOS, and if she gives you history of previous OHSS, remember she is more likely to have OHSS. Dr. Chaitanya has already highlighted that in IUI cycle, when you should not give that banduk ki goli, because HCG here is the trigger, your banduk ki goli. So if you see 2 or 3 dominant follicles at the time of trigger on your ultrasound, you have to avoid giving SCG cycle. You have to document on the case paper that IUI cycle is cancelled, and you have to advise abstinence to the couple. I know many couples, they don't listen to us, but to be on safer side, from medical legal point of view, do document that you have cancelled the cycle and you have advised abstinence to this couple. This I was talking about IVF protocols, so that you all can have OHSS free clinic. Now you are very happy. This lady has now come to you in first trimester. Either the same woman is continuing with her, or some other IVF pregnancy has come to you in the first trimester. So what you should look for and what you will advise. I am sure you all know that now we are practicing this inverted pyramid of care, that is more and more surveillance is done in the first trimester, and it helps us in dividing high risk and low risk in the very first trimester itself. Now if she is coming to you when she is 6 to 7 weeks pregnant, what you all are supposed to do? Definitely we advise ultrasound at 6 to 7 weeks of pregnancy. Why? Because we want to know the exact dating of the pregnancy. We want to know whether it is intrauterine, it is ectopic, or it is a heterotropic pregnancy. You want to know whether it is a case of missed abortion, that is only you are seeing the sac but there is no fetal pole inside. You want to know whether it is a single pregnancy, twins, triplets, or what is the multiple pregnancy. And if at all it is a multiple pregnancy, this is the best time to see the chorionicity of that multiple pregnancy. So now at this stage, what you should know? Fallen ART, the risk of miscarriage may seem a bit higher, because all the literature is saying that risk is higher than spontaneous pregnancy. But is it really so? Because it can be because of the early pregnancy detection, because we are doing sonography at 6 to 7 weeks on one hand, and on the other hand, it can be because of the advanced maternal age. But yes, you should know that the risk of miscarriage is slightly higher. Multiple births, I already said, yes, it is because of the practice of transferring more than one embryos what we are transferring. Can multiple births be prevented? Yes, by having strict limit on the number of embryos that may be transferred. I know this law is there in many countries where ART centers cannot transfer more than one embryo transfer. That is, they have the policy of single embryo transfer. But this policy is not universally followed or accepted. Remember, even if you have transferred single embryo, spontaneous splitting of embryos in the womb can occur. Yes, it is rare, but it can happen, and if this happens, it will lead to identical twins. What about vanishing twins? Because this also everyone should know. In IVF pregnancies, twins are more often conceived than born, because most of them, they vanish in due course of time. The true incidence of vanishing twins is difficult to assess in IVF pregnancies, but according to one data, it is estimated that 30% of these twins, they will ultimately result in singleton pregnancy, and 10% of them will end in complete abortion. If it is a monochorionic twin, you all know that there are chances of more complications because of shared placenta in the form of TTS, single twin demise, monoamniosity, trap, and because of conjoined twins. Now, if it is a case of multiple pregnancy, which in majority of IVF pregnancies will be the case scenario, so your aim of antenatal care in these cases will be to prolong the gestational age and increase the fetal age, to improve the perinatal mortality and morbidity, and decrease the incidence of maternal complications. So what will be the aim of your antenatal care? Of course, it has to be a consultant-led team. Embryo reduction, yes, at 11 to 13 weeks of gestation. It is best done after 11 weeks of pregnancies. You have to call her more frequently. You have to give her folic acid supplementation, assess the cervical length and competency, and careful watch for complications. Because if it is a case of multiple pregnancy, you know that this mother is at higher risk for hyperemesis gravidum, abortion, hypertensive diseases. It increases by 4-fold. Gestational diabetes, preterm delivery, anemia, hydramnios. Don't forget the GIT symptoms as well in cases of multiple pregnancy. They can have increased incidence of reflux, abdominal discomfort, bladder symptoms, hemorrhoids, APH, and thromboembolic diseases. Because of multiple pregnancy, the fetus is also at increased risk in the form of increased perinatal mortality, morbidity, preterm delivery, and low birth weight. I am just coming to the embryo reduction. Embryo reduction we do only if there are more than 2 fetuses. For twins, no center is doing embryo reduction. So triplet onwards, it is done. It is best done after 11 weeks, but because by that time, 30% of the twins, they vanish on their own. There is a 10% risk of miscarriage. But also remember that these multiple pregnancies which are conceived by IVF, they have good outcome as compared to the twins who are conceived by natural pregnancies. Why? Because of high level of prenatal monitoring, high level of awareness, high level of patient compliance, these multiple pregnancies have good outcome. Are congenital anomalies increased in these IVF pregnancies? You can see that I have quoted many studies, and again there are so many studies which are telling you that a detailed obstetric ultrasound should be performed for pregnancies achieved with IVF and ICSI, that is grade 1B recommendation. Congenital heart disease, is this risk increased in IVF pregnancies? I know for other pregnancies, we don't do fetal echocardiography, but for IVF pregnancy, we do recommend fetal echo at 22 weeks of pregnancy. Hyperemesis is a big challenge, and how to screen her for congenital and biochemical markers is doing a NT scan at 11 to 13 weeks. Now here everyone should know whether this IVF cycle is done by a self-egg, that is her own eggs, or it is a donor egg cycle. Because if the mother's age who is pregnant is 42 years and you are sending her double marker, you will not be able to interpret, because the donor in this case usually will be in the age range of 25 to 28 years or something. But you cannot ask this history in the front of everyone, full house, because usually this is a very sensitive subject. Most of the times only couple knows, even their parents and relatives, they are not aware that this is the baby conceived by a donor egg. So you have to be very discreet, but you have to definitely ask whether this pregnancy is by your own eggs or by donor egg. Now what is this time you will be doing? Of course, NT and soft tissue markers. You will look for cervical length. Don't forget to do post-speculum examination. I know you are having a busy OPD, but post-speculum examination should be done in each and every pregnancy. So this is the algorithm which we follow at 11 to 14 weeks for these pregnancies. And as I said, inverted pyramid of care. So apart from your aneuploidies and all, it will also tell you about the risk of gestational diabetes, preeclampsia, risk of preterm labor, placenta previa. You all can predict in first trimester itself. Don't forget to monitor her for asymptomatic bacteriuria and chlamydial infection. So when you should start the screening for cervical length, it has to be started from 11 to 13 weeks onward. And what is the cutoff for singleton pregnancy? It is 25 millimeter, that is 2.5 millimeter. Do you have to put stitch routinely to all IVF pregnancies? The answer is no, because the routine stitch does not help, and in most cases what we are already giving, progesterone, is more than enough. But of course you have to individualize every case. Now either this lady is continuing with you and she has reached 18 to 20 weeks, or some other new patient has come to you when she is 18 to 20 weeks of pregnancy. So 18 to 20 weeks is the period for anomaly scan and quadruple marker. So again you have to ask, if the same patient is continuing, you know it is a self-egg or donor egg cycle. But if it is a new patient, you have to again ask whether this is a self-egg cycle or a donor egg cycle. Again, look for cervical length measurements, first speculum examination, and as I already said, we do fetal echo at 22 weeks of pregnancy. What about the risk of PIH in IVF pregnancies? Studies are saying after adjusting for maternal age, interbirth interval, and presence of new partner, women undergoing ART, they have a small increase in odds of preeclampsia. Is this risk of preeclampsia more in donor egg cycle? Yes. Pregnancies achieved with OD, that is egg donor cycle, they had more than double the risk of preeclampsia when compared with other methods of ART, and more than fourfold increased risk compared with natural pregnancy. So you should know whether it is a self-egg cycle or a donor egg cycle. Now in those pregnancies which has been achieved with IVF, does low-dose aspirin prophylaxis reduces the risk of fetal and placental complications? These are the guidelines from Society of Fetal Medicine. We mean Society of Fetal Medicine. They do not recommend low-dose aspirin in those patients with an IVF pregnancy as the sole indication for preeclampsia prophylaxis. However, if one or more additional risk factors are present, low-dose aspirin is definitely recommended. Two systematic reviews and meta-analysis have shown that the probability of PTROM is significantly increased after ART pregnancies compared to singleton pregnancies, both in compared to spontaneous pregnancies, both in singleton and multiple pregnancies. So that is why I was emphasizing the importance of doing post-speculum examination and monitoring her for cervical and vaginal infections. Is the prevalence of spontaneous preterm birth higher in IVF pregnancies? You can also see the studies which I have quoted. A meta-analysis of singleton pregnancies demonstrated that IVF is associated with higher odds of preterm delivery, low birth weight and very low birth weight compared with naturally occurring pregnancies. Is the prevalence of fetal growth restriction higher in IVF pregnancies? Yes. An increased risk of small for gestational age infants is documented for singleton IVF pregnancies. Meta-analysis have described a higher risk for SGA babies in IVF ICSI pregnancies from fresh cycles compared with frozen cycles. So whenever it is an ART pregnancy, you should know a self-egg cycle or a donor egg cycle as well as a fresh cycle or frozen cycle. By fresh cycle, we means that we have done egg pickup in the same cycle and we have done embryo transfer in the same cycle. Either a 3-day embryo transfer or on day 5 we have transferred blastocysts. But if we have frozen all the embryos and we are transferring in the subsequent cycle, then it is called as a frozen thaw cycle. So again, the outcomes differ in fresh cycle and frozen thaw cycle. Now the patient is in the 3rd trimester. So what are your goals? Of course, you have to monitor closely for fetal growth, for preterm labor, and you have to monitor placenta for adherent placenta or placenta previa. Why I am saying so? Why I am emphasizing again and again about placenta? Just see these studies which will answer, are placental anomalies increased in IVF pregnancies? Yes, definitely. IVF pregnancies are associated with higher risk for abnormal placental shape, that is bilobed placenta, accessory placental lobes, placenta previa, marginal or velamentous cord insertion, and placenta accreta as compared to naturally occurring spontaneous pregnancies. What about the risk of placenta previa? In a meta-analysis of 15 cohort studies comparing ART conceived with naturally conceived dichorionic twins, women who had ART dichorionic twins had nearly 3 times higher risk of having placenta previa as women with naturally conceived dichorionic twins. So you have to pay special attention to placenta in these IVF pregnancies. What about antenatal corticosteroids? Yes, the Society of Fetal Medicine definitely recommends a single course of corticosteroids between 25 to 34 weeks of gestation who are at risk of preterm delivery within 7 days, including for those with ruptured membranes and multiple gestations. What about the fetal care? Because every time we are talking about maternal care only, of course you have to do NT and soft tissue markers, your anomaly scan, fetal echo, and you have to do serial ultrasound and Doppler evaluation for this baby. The best method for antenatal fetal surveillance here is definitely the fetal kick count. Why? Again, the risk of stillbirth is definitely higher in IVF pregnancies. That to the tune of 2 to 3-fold increased risk of stillbirth, that too after controlling for maternal age, parity and multifetal gestation. So you have to be very, very alert as far this risk is concerned. These are various methods which are available in your armamentarium. But what you can educate her most is about the kick count. There are many charts which are available on Google. You can download one, you can tell her, you have to educate her. There are 2 ways to record the fetal kicks. One is the Cardiff count to 10 method and another is 1 to 2 hours method. So you have to tell her If the counts are less than 10 in a day, she has to report to you, that is to a hospital. There are various charts available. Now coming to the time of delivery. In pregnancies which are achieved with IVF, does delivery at 39 weeks reduce the risk of adverse perinatal outcomes? It is currently unknown whether elective delivery at 39 weeks reduces the risk of maternal morbidity and improves perinatal outcome in IVF pregnancies compared with expected management. So in the absence of studies focused specifically on time of delivery for IVF pregnancies, the Society of Fetal Medicine recommends shared decision making between the patient and the healthcare provider when you are considering induction of labor at 39 weeks of gestation. I know you all know very well how to do the intrapartum care, whether it is a singleton pregnancy or a multiple pregnancy. Fetal monitoring, whether you should do by your fetal Doppler or continuous fetal monitoring, you have to again individualize, because the comparisons of electronic fetal monitoring and intermittent auscultation have shown that EFM increases the likelihood of cesarean and vaginal instrumental delivery, infection and cerebral palsy in premature babies. Now, mode of delivery. It is $1 million question for IVF pregnancies, whether you want to deliver them by LSCS or by normal vaginal delivery. But yes, all the guidelines are saying that they are not a case for elective cesarean section. Cesarean section should be done for obstetric indication only. I don't know how many cases come to you for these LSCS on demand or Muhurat LSCS, but in private practice for IVF pregnancies, usually these patients, they do pressurize us for Muhurat LSCS. When I was also new in practice, we used to do at 2 a.m., 3 a.m. But now we tell them to bring your Panditji with you if he is giving you Muhurat of 2 a.m. so that he should be present to look after your baby. Otherwise, you have to do in our routine OT hours. Don't forget the babies, they are at increased risk of perinatal mortality and morbidity. बच्चा हो गया, सब बच्चे भी busy हो गए, but you obstetrician cannot afford to do so because you are responsible for the postpartum care as well. Remember, these IVF pregnancies are at increased risk of puerperial psychosis. There are increased risk of lactation problems. You have to monitor the comorbidities, and of course, you have to take good neonatal care. Is maternal morbidity increased in cases of IVF pregnancies? Yes, the maternal morbidity is nearly twice as likely as compared to the naturally occurring pregnancies. Mortality, no woman dies just because she has undergone IVF. The slight risk of maternal mortality can be because of her higher age and because of pre-existing comorbidities. So counseling and counseling. We all counsel them, but many couples, they downplay this risk or they even ignore this risk due to their desire to have a children. So we have to counsel them about the worsening of pre-existing medical condition, increased risk of chromosomal abnormalities, the risk of multiple pregnancies, risk associated with advanced maternal age, and psychological impact. What is the psychological impact? Especially it is more if the fetal reduction is done, or if there is a vanishing twin, or there is a death of one twin. You are definitely calling them for more frequent monitoring. If there is anomaly in one fetus, if there is a risk of preterm delivery. Remember, these pregnancies, they cause more financial burden. Even if we tell them don't take bed rest, many of them, they do apply for leave and they take bed rest. So job worries are also there with them. This was all about psychological impact. What about the medical legal issues? So medical legal issues can occur if you fail to diagnose twins, if you overdo the test, but on other hand, if you are not doing the required number of tests, again you are head for medical legal problems. if there is a late detection of growth problems or wrong estimation of gestational age. So beware of medico-legal issues when you are handling these IVF pregnancies. So friends, the key takeaways from this presentation is that pregnancies achieved by IVF or ICSI are definitely at higher risk for obstetrical and neonatal complications than spontaneous pregnancies, and close surveillance during pregnancy should be considered by all the care providers. It remains unclear if these increased risks are attributable to the underlying infertility, characteristics of the infertile couple, or use of assisted reproductive techniques. Multiple gestation remains a significant risk. So what you all can do, you have to treat each pregnancy as a high-risk pregnancy. It has to be a multidisciplinary approach where you have ART specialist, the high-risk pregnancy specialist, the fetal medicine specialist and neonatologist in your team, and early screening and prediction of potential problems and detection and treatment of this potential problem will give you an optimum healthy outcome. So thank you friends, thank you so much for your patience here.
Nice deliberation, ma'am. In this era of modernization and urbanization, this incidence of infertility again very skyrocketing, and this as the endocrine milieu is not normal in this patient, that is why they require the assisted reproduction technologies.